The following podcast is part of a certified educational activity titled Transforming the Treatment of ATTR, a guide to the pathophysiology, diagnosis, and emerging treatment strategies for ATTR amyloidosis. Access the entire activity and complete the post-test at peerview.com/TDS860. Downloadable slides and practice aids are also available.
Hello, and thank you for joining us for what we hope to be a very exciting discussion of a very exciting field, transforming the treatment of ATTR amyloidosis, a guide to the pathophysiology, diagnosis, and emerging treatment strategies for ATTR amyloidosis. My name is Ronald Witteles. I'm professor of cardiovascular medicine and co-director of the Stanford Amyloid Center at the Stanford University School of Medicine.
And thank you, Dr. Witteles. My name is Julie Rosenthal. I'm an assistant professor of medicine at Mayo Clinic, Arizona. I'm the director of our cardiac amyloidosis program. Pleasure to be here.
So our goals for today are to learn the overlapping cardiac and non-cardiac signs and symptoms of all forms of ATTR amyloidosis, including the variant and wild-type form causing cardiomyopathy, as well as the variant form causing polyneuropathy. To understand the guidelines to diagnose and monitor ATTR cardiac amyloidosis, to augment your knowledge of the clinical trials for emerging treatment options for ATTR amyloidosis and the implications for clinical practice, and to help you to create multidisciplinary care plans for patients with ATTR amyloidosis, including the use of targeted therapies. So we're going to do this in 4 modules. And we're going to start now with Module 1, which is the scope of the problem. We want to understand the epidemiology, the pathophysiology, and the burdens of ATTR amyloidosis. So here you see a diagram showing in broad forms how ATTR amyloidosis happens. The terminology comes from A for amyloid and TTR for the name of the protein, transthyretin. This is a protein, it's also called prealbumin, that is produced by the liver, and it circulates in the bloodstream primarily as 4 subunits basically bound together, what we'd call a tetramer. And that's a stable form as it circulates. However, it's always in steady state with a small amount of monomers, single units, which can misfold. And when they misfold is when they can now start stacking into amyloid fibrils, which deposit extracellularly in tissues, including, of course, the heart. Broadly speaking, there are 2 types to think about. The wild-type form of the disease, where somebody is not born with a hereditary mutation. This is the normal transthyretin protein that most of us have, that just by its very nature, by its very structure, is prone to gradually misfold and deposit over time. The other less common but very important form is a hereditary, or what's sometimes called variant form of the disease. And here, there are over 130 pathogenic variants that have been described in the single protein that can make it more likely to misfold and deposit. And depending on what the mutation is, really drives the phenotype of the disease. And this slide here gets at that exact point. And so this is by no means an exhaustive list. This is just some of the more notable mutations. And as you can see, depending on the mutation, on the left side of your screen, you see some of the mutations that tend to have more predominant neuropathic features, where they're depositing in the peripheral autonomic nervous system. And as you go to the right, you get more predominant cardiac features. Now, the exception is that the wild-type form of the disease, really, it's not clear that it causes any significant neuropathic involvement. As we'll talk later, there can be some symptoms from nerve compression when it's depositing in the soft tissue. But in terms of real deposition in the nerves, you don't tend to see that with the wild-type form of the disease. Now, some of these mutations matter more than others in terms of encountering them in clinical practice. And the one by far the most common that we will encounter in the United States is the one all the way on the right there, V122I, which is seen in about 3 to 3.5% of individuals of sub-Saharan African descent. So that's a pretty high number when you consider the number of individuals of African descent in the United States. Not everybody with the mutation will develop the disease, but they're more likely to. And as you can see, it tends to be more of a cardiac presentation. On that point, here is some data from a registry called TAUS, which has been a longstanding registry, mainly at amyloid centers in the United States and around the world. Now, what you can see is on the left, the breakdown in the United States, and then in the middle, you can see the breakdown in the rest of the world with what was being encountered. Now, you'll note that wild type was slightly less than half in the United States and was a small sliver around the world. But I don't want you to be fooled by this. And actually, let me turn to Dr. Rosenthal and get your thoughts about the accuracy of this data and what you see in your clinical practice.
Thank you, Dr. Witteles. I would agree there seems to be quite a discrepancy between what's represented here in the United States compared to the rest of the world. And I think this highlights things that are very real and touch base here at home with regards to healthcare disparity and access to specialty testing, as well as we'll talk about later, disease-targeted treatments. So my hope, and I believe your hope, is that our colleagues here leave this seminar recognizing, understanding that TTR amyloidosis is not a rare disease. It just overall is under-recognized and underappreciated. And it really just depends on the touch point in healthcare that our patients are having today.
Thank you. And I think it is fair to say that the actual reality of this is that both of these circles should be dominated by light blue, that wild type is by far the most common form of the disease encountered anywhere in the world. But when you start getting into specific mutations, now the patterns of the inheritance patterns of a community really matter. And then, as you highlighted nicely, what can be very real disparities in access to care. And so getting at that point, here is the information that some ATTR variants are not that rare. Now, I just want to mention on the nomenclature, you will see this called two different ways. So you see here P.V142I, and then in parentheses V122I. And for people who aren't used to looking at inherited cardiomyopathies, for example, this nomenclature can seem confusing. It's referring to the same mutation, whether or not you're counting in there an extra 20-segment amino acid sequence. So I want to be clear, if you have a patient who has quote-unquote V142I amyloidosis, that's referring to the same thing. So just to keep that in mind. As I said, about 3 to 3.5% of individuals of African descent in the United States carry this mutation. And it really tends to cause predominantly a cardiomyopathic phenotype. Now, thankfully, we have seen changes in outcomes in ATTR amyloidosis for several reasons. So here is some data that you can see looking at overall cardiac amyloid survival on the left, and then specifically in the V122I mutation carriers who have the disease on the right. And the different colors are denoting different eras. So the earliest being 2002 to 2006, and the latest in this data set being 2017 to 2021. Now, keep in mind that the improvements that you see in time here are really not driven by amyloid-specific therapies, because until the last portion of time, where only a sub-portion of it was any therapy available, that being the first to be approved tafamidis, but that wasn't until 2019. So most of the improvement is really just an earlier diagnosis that has happened with better awareness, and as we'll talk about a little bit later, more access to easier diagnostic paths. The clinical manifestations of the disease, as cardiologists, we understandably and arguably appropriately focus here on the left, which is the cardiac manifestations, the heart failure and the arrhythmias, of which atrial fibrillations and heart block are really the most common. But the other ones to keep in mind, number one, are the musculoskeletal manifestations, things like carpal tunnel syndrome, lumbar spinal stenosis, trigger finger, biceps tendon rupture. And then patients who have the variant forms of the disease can get polyneuropathy. And again, that can be with peripheral neuropathies or autonomic dysfunction. So with that, to close out this section, I want to go through a case that we're going to come back to throughout the presentation, and to get Dr. Rosenthal's thoughts on this. So this is Malcolm, who's a 60-year-old man of Irish descent, who 6 years ago was diagnosed with atrial fibrillation. He's had hypertension, but as you can see, reasonably controlled. And he has stage 3 chronic kidney disease. About a year ago, he was diagnosed with heart failure with preserved ejection fraction. And overall, also over the last couple of years, he's developed some numbness and tingling in his feet, as well as some diarrhea and weight loss. He has no notable family history, and you can see his medications are what might make good sense for somebody with hypertensive heart disease and HFpEF as well as atrial fibrillation. And so he's been referred to you by his primary care provider for really help managing his atrial fibrillation. And his main symptoms are of leg swelling, feet tingling, and exertional dyspnea. So, Dr. Rosenthal, let me turn to you. So when you see this, what do you notice that from his exam and his history and anything that you see as red flags for this disease?
Thank you. Yes, I think a few things stand out. Particularly, I'm seeing and hearing history of numbness and tingling for the last few years. When we look at his med list while he's on supportive care with gabapentin for presumptive neuropathy, we're missing the most common cause for neuropathy, at least here in the United States, which would be things like diabetes mellitus. In addition, why is he having some exertional dyspnea? Now, we know heart failure with preserved ejection fraction can have that, but it seems like overall he's pretty well compensated. He's on minimal diuretics. We didn't hear that there were significant features aside from lower extremity swelling concerning for worsening heart failure. So I have to think about a maturing individual and maybe he having some chronotropic incompetence. The fatigue seems out of proportion to the dose of beta blocker. 25 BID should not be too high. Maybe we're missing other things like sleep apnea, but certainly raises a question. The other thing that stands out is the diarrhea. So I always like to get a little bit more of a history here. He's having diarrhea to cause weight loss. Is he having some nutritional deficiencies? And what is actually causing the diarrhea? That would certainly be a red flag to me.
That's great. And can I ask one final question of how you approach as a heart failure specialist? HFpEF, is that a diagnosis or a syndrome?
Excellent question. I think this is a constellation of things. We've all struggled with HFpEF and how we approach that. So I really think this is a syndrome, but we really need to exclude what is the driving factor for his HFpEF. And this should be a diagnosis of exclusion. We want to make sure that they do not have an infiltrative cardiomyopathy. We're highlighting transthyretin amyloidosis today, but ensure it's not a valvular heart disease or coronary artery disease or something that we can really modify and have disease-targeted therapies or HCM. The world is really exploding right now with different disease-targeted therapies. So in my mind, this is a diagnosis of exclusion and truly a constellation of findings, not only by history, physical, as well as objective markers, but can be challenging to make a formal diagnosis.
Thank you. And yeah, I feel like, hypertension is almost ubiquitous as people get older. And a lot of times HFpEF just gets attributed to hypertensive heart disease because somebody carries a history of hypertension. But, somebody like this who's had 15 years of presumably well-controlled hypertension the whole time, that really shouldn't cause HFpEF, and it seems to be a light bulb. Well, why don't I turn it over to you, Dr. Rosenthal, to take us into our next session.
Welcome back. This afternoon, I have the pleasure of initiating Module 2. Time is of the essence, recognizing, diagnosing, and monitoring transthyretin amyloidosis. This image of the iceberg here just highlights that transthyretin amyloidosis, when presenting with heart failure, is just the tip of the iceberg, but it's really recognizing those red flag features that will help drive you to the diagnosis of transthyretin amyloidosis, not only the cardiac manifestations, as well as the extracardiac manifestations that we'll be talking about in greater detail, and you heard during the first module from Dr. Witteles. So when we're thinking about a patient specifically with polyneuropathy that you might see in clinic with heart failure, the red flag features of this polyneuropathy will once again be those without signs or symptoms of diabetes mellitus. In addition to a progressive neuropathy in perhaps both the hands and the feet, it might also present with a lot of autonomic dysfunction symptoms, whether it's orthostatic hypotension or terrible kind of waxing and waning diarrhea. We're talking about 4 to 10 episodes of loose stools daily. They might also have symptoms from nerve compression, whether it's spinal stenosis, bilateral carpal tunnel syndrome, recurrence of that bilateral carpal tunnel, as well as trigger fingers. What about other patients you might be seeing in your cardiac clinic, specifically those you're evaluating for aortic stenosis? We know from retrospective review of both American trials as well as European trials that up to 15% of our patients undergoing evaluation for TAVR will in fact have TTR amyloidosis. So when you're thinking about these patients and you do your complete review of systems and your physical exam, as well as reviewing objective data, you want to pay close attention to that echocardiogram. Do they have increased thickness within that interventricular septum, specifically greater than 12 millimeters? Or on their ECG, do they have voltage out of proportion, specifically to that thickening you note on echo? Their ECG may also show low voltage, but not all patients with amyloidosis will have low voltage, so that's an important feature. Certainly, when you're thinking about these patients, please ask the question, could this patient have amyloid? So thinking about that heart failure patient, whether it's heart failure with preserved ejection fraction or heart failure with reduced ejection fraction, as Dr. Witteles and I share with you this morning, how do we think about heart failure with preserved ejection fraction? By definition, these are symptomatic patients with an EF greater than or equal to 50%. But there are a lot of mimickers to patients living with heart failure, right? Not all edema is the same. So Dr. Kittleson and colleagues in our most recent guideline statement asked us to sort of go through this diagram to make sure that we're not missing classic mimickers for HFpEF, and we don't miss that infiltrative cardiomyopathy that we're talking about today, transthyretin amyloidosis. So we want to make sure they're not living with cirrhosis, chronic kidney disease, which is a common comorbidity in our patients. But then look at this heart failure with preserved EF. Could this be due to hypertrophic cardiomyopathy, valvular heart disease, infiltrated disease like TTR amyloidosis? So if there's a possible yes here, I'm going to implore you to ask that question again. Could this be amyloid? And we'll be talking about shortly how we go about a proper diagnostic algorithm to make sure we don't miss that. If you've excluded these things, then you can proceed through this algorithm to make the formal diagnosis of heart failure with preserved ejection fraction. It is important not to be fooled because patients can have more than one problem, so please be sure that you exclude an infiltrative cardiomyopathy. So how about that diagnostic algorithm? Now that you've kind of clued into some of your red flags, not only from your history and physical, but from some initial objective testing, such as that ECG that might highlight voltage out of proportion to the thickness, or maybe low volts or a pseudo-infarct pattern. On echocardiogram, you may see that apical sparing strain pattern or interventricular septal thickness greater than 12 millimeters, and you ask this question, could this patient have amyloid? We want to make sure that you do not miss what I would consider a hematologic emergency, meaning primary or light chain amyloidosis. So to ensure that we do not miss this, you need to order specifically 3 tests, a serum and a urine immunofixation, as well as a serum-free light chain. If one or all 3 of those tests are positive, then you must get tissue to properly diagnose the type of amyloid. But thanks to Dr. Gilmore and colleagues, since 2016, the role of a technetium pyrophosphate scan has really increased in utilization and allowed us to make a non-tissue diagnosis of transthyretin amyloidosis. But that's not enough. If you've made a diagnosis of transthyretin amyloidosis by a positive PYP scan and a negative hematologic evaluation, then you need to go one extra step because genetic testing is important, as this has implications for potential treatment options in our patients as well as their loved ones. Dr. Witteles, anything else you would add when thinking about how to diagnose amyloidosis?
Yeah, thanks so much. So a couple of things I would add. One, I don't like to think of this as a hematology emergency because your hematologist may not consider it as much. This is a AL amyloidosis, that is, as opposed to ATTR, is a legitimately rare disease. And frankly, your hematologist may not have that much experience in it. Often in this, the actual levels of the monoclonal protein aren't that high. And so it doesn't necessarily jump out as an emergency from the hematology side. The emergency is because of where this light chain is depositing. So to me, I like to think of this almost as a cardiology emergency if we're worried about AL amyloidosis affecting the heart. And it's really on us to make sure we quickly get to a diagnosis. And often, in fact, in that case, a heart biopsy will be the best. Besides that, concur with everything you said. And I'll just emphasize, this almost looks intimidating. It's actually a really easy workup. Just rule out the monoclonal protein. And if it's negative, get that scan. And then the subtlety, as you nicely pointed out, about doing genetic testing at the end.
Thank you. So common question myself, and I presume Dr. Witteles are asked is my amyloid worsening, and how do I know? Typically in my clinic, how I follow them is how I would follow any patient with heart failure to decide if they're worsening, which would mean we have escalating diuretics with little return of response, more syncope, defibrillator firing, needing hospitalizations. But some of our colleagues actually came out with an expert consensus in terms of how to monitor. And they base this off of three main categories based on clinical and functional abilities, as well as cardiac biomarkers and imaging. How we know overall, though, that this disease-targeted therapy works, as we only have one, and we'll be hearing about that shortly, is because the clinical trial and the long-term data show us that it works. But I would say if your patient is progressing, regardless of meeting criteria in each one of these categories, this is when we really should be thinking about palliative care and or potentially advanced therapies. All of these things should be available for our patients in today's era. And here you can see a nice classic image of someone living with cardiac amyloidosis, both on echocardiogram. Hopefully you can appreciate that increased thickening response. And this is an example of a positive PYP scan, where the tracer is taken up in the myocardium and in brighter than bone. Getting back to our young gentleman, Malcolm. On his echocardiogram, we see that overall there was increased thickening with a reduced ejection fraction. He did undergo a hematologic evaluation that was negative, and next he underwent his PYP scan that was positive. Subsequently, he was referred to the appropriate specialists. Overall, this was consistent with hereditary TTR amyloidosis. Dr. Witteles, anything else you think we should add in our workup or questions we should ensure that our colleagues know to ask their patient when going through the process of amyloidosis workup?
Thanks so much. Yeah, in fact, I want to make one point about how to monitor the patients as we were discussing, and then talk a little bit about this gentleman. So in terms of monitoring, you nicely outlined the document that had been put out by some experts in the disease about how to monitor. I think that's still an open question because we can monitor and say somebody's disease is getting worse, but I'm not sure what to do with that data. And patients will often ask, how do I know if I'm getting better or not? And I'll usually tell them they can tell me before I can tell them. They're the ones living with the disease and knowing how they feel. And to date, as you note, there's only been one therapy. We're hopeful that's going to change soon. So hard to know what the real standard of care should be, I think, for monitoring disease right now, once you've made the diagnosis. Now, in terms of Malcolm, so notably, he had the diagnostic pathway followed, correctly got to the diagnosis, and then got the genotyping that we can see showed this T60A variant. And that is one of the more common variants that we encounter in this country. It actually is most common in individuals of Irish descent, so it fits for him. And it's one that really does tend to have multi-organ system involvement. And in fact, the most common will be the heart, the nerves, and the gastrointestinal tract. And the symptoms follow that deposition. And so this is somebody who really does need multidisciplinary care from the cardiologist, from the neurologist, from the gastroenterologist, and then, of course, with appropriate genetic counseling, as well as from the genetic counseling standpoint, advice for what to do for his family. Well, next we turn to our Module 3, which is, to me, the most exciting of all, because it's really the game-changing that we have had with the new and some not-so-new ATTR-targeted therapies, and just the explosion that has really happened in this space. So, as I noted earlier in Module 1, the transthyretin protein is produced by the liver, can then misfold as it's circulating, form fibrils, and deposit in the heart and elsewhere. So one of the things that's so exciting about this therapeutic space is that it's not just random drugs that were tried that happen to work or not work. These are drugs that were designed to do exactly what they do, and we now have had several really big success stories, with many we hope to come. So the approaches to treating this disease with disease-targeted therapies, on the left you can see what's called RNA silencing. And what this means is that by two similar but ultimately distinct mechanisms, you are causing the liver to simply produce less transthyretin by on the order of 80% or so. And so with only 20% or some odd of the transthyretin circulating, no surprise, you have a big change in progression of the disease. There's also being developed a gene editing approach, which would be a single one-time therapy that could knock down production by maybe even more than that 80%, and just permanently changing the genetic code in the liver where it's being produced. Now, the second main approach is what is called the stabilization approach. And this works by binding to the thyroxine binding site. The name transthyretin comes from transports thyroxine and retinol. That's what the protein does. And it turns out when you bind to the thyroxine binding site, it stabilizes that tetramer form. And so theoretically, I suppose you could give somebody lots of thyroxine, but that wouldn't work because you'd make them hyperthyroid. So there's other approaches. And so 3 different agents have been tried, all of which work by ultimately binding to that site. One of them is a nonsteroidal anti-inflammatory drug called diflunisal that binds. A number of NSAIDs do. This one does the best. And then 2 others that were specifically developed for this, tafamidis and acoramidis. And then finally, there's a question of, well, once amyloid fibrils have been deposited, can we actually do anything to remove them? And so there is some exciting work being done there with monoclonal antibodies to actually try to bind to the deposits and cause clearance from the tissue. Now, as you can see with the check marks, there are already multiple drugs that are approved. And so we have 4 silencing agents that are FDA approved for the disease, but only so far in ATTR polyneuropathy, not because we don't think they would work in cardiomyopathy, but the original trials were in polyneuropathy. As we are recording this in September 2024, we have had a recent trial result with vutrisiran in cardiomyopathy that was very positive and hopefully will lead to a FDA approval in the not too distant future. Similarly, from the middle column, acoramidis earlier this year published a very positive phase 3 trial, and we're hopeful that will lead to FDA approval as well. And then eplontirsen, another silencer, is in the middle of a very large cardiomyopathy trial with results expected in the not too distant future. And here is the timeline, and it gives you a sense of just how much work has been done, and particularly over the last, say, 7 years. And so you can see the list of trials. That diflunisal trial was done by Burke and colleagues, published back in 2013, showing some improvements in polyneuropathy outcomes. But I'd say the modern day really exciting trials from drugs specifically developed for this disease really came out, as we can see, 2017, 2018, with 2 trials for polyneuropathy and then tafamidis for cardiomyopathy. And that really set the standard for tafamidis being the standard of care for patients with ATTR amyloidosis. We'll see the data shortly. But then you see how much has been happening the last few years and into the future. And so we've had a series of trials, both establishing 2 more silencers in polyneuropathy with HELIOS-A and NEURO-TTRansform, and then the trials you can see above, which have established roles in cardiomyopathy now for both acoramidis and vutrisiran. CARDIO-TTRansform is the study of eplontirsen I was referring to earlier, 1,400 patient trial, by far the largest in the field that's expected in the next couple of years. Dr. Rosenthal, this is pretty remarkable growth. What's your take been?
I could not agree more, and I think we could not be remiss without thanking some of our colleagues also in the imaging and the diagnostic arena, because I think most of our colleagues thought this was a rare disease, but thanks to people like Dr. Dogan, in 2009, our gold standard for how we determine the type of amyloid really became standard of care with tissue typing using mass spec, so that now allows us to recognize different types of amyloid. In addition, in 2016, we have increasing ability to detect with PYP coming to the forefront of our care as well. And there are additional imaging modalities undergoing research too, which I think has helped create excitement for the field. And then thanks to our basic scientists and translational scientists has really helped launch us forward. So now we have actually disease-targeted therapies for our patients, and it's not just calling palliative care and pastoral care for our patients. So just an exciting time to be an amyloidologist.
It's such a great point, and amazingly, you had that proverbial perfect storm of the same moment almost that we had our first therapeutic option with tafamidis for cardiomyopathy, coincided with right around the same time where PYP scans became standard, accepted way of making the diagnosis and available. So we went from the only way you could diagnose was typically with a heart biopsy, and by the way, you couldn't do anything about it if you made the diagnosis, all of a sudden to most patients can be diagnosed non-invasively, and we can do something to really change outcomes. So moving on here, this really gets at an important point, which is that racial and ethnic minorities are really underrepresented across ATTR amyloidosis clinical trials. Unfortunately, this is not a story unique to ATTR amyloidosis, we know, but it's in some ways particularly bad here because of what we were discussing earlier, where you see that the most common inherited form of the disease, that V122I mutation, which is seen almost exclusively in individuals of African descent, really you would think should lead to a larger percentage of individuals of African descent in clinical trials than even is the population. And unfortunately, that's not been the case. And it's a real challenge for our field.
I would just add that this provides an opportunity for us in healthcare to really work on establishing trust within our patient communities, as well as establishing diversity within the healthcare team to make individuals feel more comfortable.
Thank you. Absolutely. So let's move on now to the exciting results from the clinical trials. So we were talking about this before, but here's the data. This is, again, the ATTRACT clinical trial, the first major clinical trial to be performed in patients with ATTR cardiomyopathy. And, as we'll see, I think we've gotten a little bit spoiled in the field with these kinds of results. But when you take a step back, they're really remarkable. So this was a trial of 441 patients randomized to tafamidis, the stabilizer medication, or placebo. And the primary endpoint was a really hard endpoint. It was a tiered endpoint of mortality and then cardiovascular hospitalizations. And take a look at the results. So the mortality curves stay the same for about the first 15 months, and then they separate and they keep separating. And by the time you get to the end of the trial, you're talking about a number needed to treat of only 7.5 people to save a life after 2.5 years. And then look at time to first cardiovascular hospitalization on the right. These curves separate at about 9 months. And by the time you get to the end of the trial and you tally up all of the cardiovascular hospitalizations, the number needed to treat is only 4.5 to prevent one cardiovascular hospitalization every year. That is a massive treatment effect. And if you compare that to other heart failure trials, it blows everything else away. So really, we don't want to underestimate just the magnitude of the difference. Here are some very important key secondary endpoints. The distance a patient can walk in 6 minutes on the left, and then quality of life as objectively measured by the KCCQ reporting system on the right. And what we can see here is that both curves separate from the very beginning, and they just keep widening as you go on. But importantly, you'll note both groups worsen. So this is not a cure for the disease. And I'm always careful when I'm starting a patient on this medicine to tell them, don't expect to feel better in a year than you do now. I hope you do, but don't expect to, because what this does is it slows progression of the disease. And I will say patients are often disappointed when they hear that, but when you see the difference and the magnitude of the difference, we can't ignore just how large this effect is. The other thing I remember when I first saw these curves that struck me was two things. One is how consistent they were. I mean, it's almost a straight line for each of the curves, and that it's actually pretty narrow error bars when you look at them. So it's saying that these were pretty predictable declines in these populations. So tafamidis really did change the treatment paradigm for this disease, and it was approved in the United States in 2019 and in the EU in 2020, although I would say approval and access are two different things. And particularly in Europe, it has taken a long time for access to improve. In the United States, there weren't quite the same access issues, but real cost issues for patients. It's a very expensive drug. I would say this has gotten easier as some of our rules have changed around copays, but the cost is still a challenge. Now, one of the important things that we have now seen across the amyloidosis clinical trials is the importance of early diagnosis. And this is for two reasons. One, of course, when we have a therapy, we always want to diagnose people early so we can start it early. But the other interesting thing, and this again has been seen now across 3 different phase 3 trials, is that patients who are sicker at baseline don't seem to have the same degree of treatment benefits from the drugs as do people who are earlier. Now, to be clear, they still benefit. So I don't want anybody to take away from this to only start this in early patients. But you can actually have a biggest treatment effect when it is started earlier. And if you look at the graph here on the right, this is looking at patients during the ATTRACT clinical trials we were looking at for the first 30 months. And then you see that vertical dotted line, and that's because 30 months are now done. And now everybody is able to switch onto open label tafamidis. And what we're looking at in the 2 curves, the upper curve is the patients who were originally randomized to tafamidis and then, of course, stayed on tafamidis. And the lower curve is the patients who were randomized to placebo and then switched over to tafamidis. And what you can see is that what you have lost by month 30, you don't get back. That decline is forever. And so even though now you start attenuating the slope of that curve once they switch on to tafamidis, you've already lost a lot of people. And this is looking at survival, but you will see the same thing if you look at things like markers of heart failure. Yeah. So this is a trial called APOLLO-B. This was a trial of a silencer patisiran, and it was a short trial, only 1 year. And it was trying to get approval based on change in 6-minute walk test. And this was actually a positive trial, a statistically significant benefit with less decline in the 6-minute walk test compared to placebo. There were no safety issues, and so it met its primary endpoints, and the secondary endpoints, most of those were hit as well. Controversially, the drug was not approved by the FDA for this indication. It actually did get a positive vote in an advisory committee, but ultimately wasn't approved because it was felt that the magnitude of the treatment effect wasn't large enough to lead to FDA approval. It's controversial, but thankfully it becomes a moot point with later data, as we will see. This is one of the 2 big trials that have come out in the last year, and this is with acoramidis. So this is an agent that also works as a stabilizer, but at least in a test tube is more potent as a stabilizer than is tafamidis. So this was a tricky trial to conduct because by the time this trial started, tafamidis was already FDA approved in the U.S., but we wouldn't expect a huge benefit of acoramidis on top of tafamidis. So it's kind of tricky to design. So the way they ended up designing it was to say enrollees could not be on tafamidis for the first 12 months, but after that could get on it, and a modest number of people did. But it was looking as a placebo-controlled trial. And what you can see is that it, too, was very effective. Now, the primary endpoint was a tiered endpoint across 4 different markers. We're going to focus here on the hard endpoints because it would have hit on this as well. So all-cause mortality barely missed statistical significance. I think when you look at the curves, there's not a lot of question that it would have gotten there if it was followed a little bit longer or a few more patients, but it just missed statistical significance. Time to CV mortality or first CV hospitalization, as you can see, that is really impressive. It separates at about 3 months, and it keeps separating as you go on. And maybe the most impressive thing of all is that in this trial, acoramidis lowered the probability of CV hospitalization by 50%. So that means for every 2 patients in the trial, the ones who were treated on acoramidis, you would have saved, for every 2 hospitalizations for patients in the trial, if you got randomized to placebo, you would have saved one of those hospitalizations had you been randomized to acoramidis. Just a massive treatment effect that is almost unheard of in a cardiovascular clinical trial. These are some of the secondary markers. You see an attenuation in the rise in the NT-proBNP level right from the beginning. You see favorable effects on 6-minute walk distance in the acoramidis arm, again, quality of life by KCCQ, and the change in serum transthyretin level, somewhat counterintuitively, when you stabilize transthyretin, the actual serum level goes up. So having that rise in serum transthyretin is actually a marker of stabilization. Well, let's move on to this trial here, HELIOS-B. So this is looking at a silencer called vutrisiran, which again knocks down TTR levels by about 80%. So this was a phase 3 clinical trial, 655 patients, randomized 1-to-1 to this agent, vutrisiran or placebo. Now, unlike tafamidis and acoramidis, this is a subcutaneous injection given every 3 months. I will emphasize that the data for this for polyneuropathy, as we'll see, is spectacular. And so there was a lot of hope to say, well, if it works so well for polyneuropathy, shouldn't it for cardiomyopathy? And here's the data, and thankfully the answer is yes, it works really well for cardiomyopathy. So you can see here the all-cause mortality on the left, and then time to first cardiovascular event. So this is, you can largely think of as hospitalizations on the right. And we can see here that the all-cause mortality curves, it takes about 1.5 years to start separating. By the time you get to 2 years, it really starts separating. And they followed patients out to a maximum of 42 months. And you can just see how massively that separation becomes as you get to the end. And similar to that time to first event, again, this is mainly cardiovascular hospitalizations, you can see takes about 6 months to separate, and then it really does. Now, an important point here, as you can see on the top, is that 40% of the patients were on tafamidis at baseline. So they also pre-specified, had done a separate primary endpoint of looking at these same outcomes in the monotherapy population, meaning patients who were not, the 60% of patients who were not on tafamidis at baseline. And maybe not a surprise, here the difference, if anything, looks even larger because they're not getting any effective therapy independent of if they got randomized to vutrisiran. And so again, you can see as you have to follow them for a little while, but once you do, the curves really separate and they seem to be increasing in their separation as you get later on. Now, one of the very large questions is, well, wait a sec, if stabilizers work and silencers work, why not have them go together? Because it makes some theoretical sense. One of them is knocking down production, the other is stabilizing what's there. Now, that was not a pre-specified endpoint for the trial, and it was not powered for that. Nevertheless, if there's obviously a lot of interest in that question, and when you look at the data, there is a pretty good trend towards the combination therapy being better, but not statistically significant. Again, it wasn't powered for that. But it gives some sense that, yeah, there probably is something to that, albeit assuming FDA approval for the drug, will insurers allow combination therapy? I'm not so sure about. And then I just want to briefly highlight CARDIO-TTRansform. Again, this is over 1,400 patients, a massive trial in terms of for this disease, that pretty similar in design to HELIOS-B, a primary endpoint of CV mortality or recurrent CV clinical events, followed for 140 months. So this is fully enrolled. Again, estimated primary completion date is June of 2025, and we all greatly look forward to this data. So I was referencing before just how effective these agents are in ATTR polyneuropathy. So what you see on the left are agents inotersen and the second-generation form eplontersen. And then on the right, the different approach, but ultimately achieving similar results with TTR knockdown with patisiran and vutrisiran. And the y-axis is something called the neuropathy impairment score. And though I know most cardiologists aren't going to be familiar with this, suffice it to say, so it's a scoring system that is meant to objectively quantify the degree of neuropathy. And to give you a sense, most people with diabetic polyneuropathy will worsen by kind of 2 to 3 points per year. Well, look at what happens in patients. Let's just focus on Apollo, for example, that the patients on placebo galloped along, increasing by 28 points in 18 months, just massive worsening of their polyneuropathy. And look at what happened on therapy. In that study, you actually had a frank improvement on therapy, just incredible. And though it says P less than 0.001, and that's true, the actual P-value here was along the lines of 10 to the minus 23rd, which I don't know about you. To me, it was unheard of. I've never seen anything like that in a double-blind randomized clinical trial. And what it gets at is the magnitude of the response and the consistency of the response. And these have just been game changers for the polyneuropathy side of the disease.
I'm questioning, what do you think about on those curves? You see almost like a reverse remodeling, like their neural impairment score is even improving, which I think makes me question from a mechanistic standpoint, what is the silencer doing maybe differently than a TTR stabilizer? Because I don't feel like we've seen that in trials like ATTRibute or ATTR-ACT, where you see this reversal. We definitely see this stabilization, but Apollo seeing that almost reversal of their neural impairment score versus NEURO-TTRansform and HELIOS-A, it's stables. Whereas in ATTRibute and ATTR-ACT, we see progression in both arms, but certainly a much slower rate of progression, as well as in now HELIOS-B. But in all three of these trials, it's almost like stabilization or improvement.
Yeah, and now we're talking about speculation, of course. To me, I think polyneuropathy, and I say this not to make it sound like we're all heroes as cardiologists, but the neuropathy from this disease is a little simpler disease. There's less going on. It's directly the toxicity of the deposition of the amyloid fibril. And so you stop that, and to me, you're taking away that ongoing injury, so a little improvement, not a surprise. Heart failure, I think it just ends up being a more complex physiology by the time you developed it. And other things, neurohormonal increase, impact of things like arrhythmias will really impact outcomes as well. That's my theory. I don't know if it's true. But I would say that I do look at this data where the silencers are so good in polyneuropathy, and it gives me more. Even before seeing the HELIOS-B data, it made me very, very positive about the potential for these in cardiomyopathy. Let's move on to just an important point, is that beyond the actual disease-targeted therapies, is we need to also think about how to treat patients with just our usual heart failure therapies. And what I would say is that, remember, these are not your classic dilated or ischemic cardiomyopathy HFrEF patients. They should be treated much more so like your classic HFpEF patient, even those who do have a modest EF reduction. So what you really want to focus on is volume management. And then what we know, SGLT2 inhibitors, we know for the HFpEF population, they work. Anecdotally and with a little bit of evidence, they seem to in amyloidosis as well. And probably MRAs have a clear role as well. The other agents, beta blockers, vasodilators, beyond treating hypertension or rate control of atrial arrhythmias, probably not much role. The other important point is that patients with amyloidosis who have atrial fibrillation have particularly high rates of left atrial appendage thrombus formation. And so regardless of their CHA2DS2-VASc score, really need to be on anticoagulation. Here is a little early data on SGLT2 inhibitors. This is not randomized data, so I don't want to belabor the point. But suffice it to say that there is some observational data that patients on SGLT2 inhibitors with this disease seem to do better. And I don't know about you, Dr. Rosenthal, but from my early experience here, it rings true. I think a lot of patients feel a lot better on these agents.
Absolutely. And I definitely see a diuretic reduction in a number of my patients once I initiate the SGLT2 inhibitor.
So this has become pretty standard. And in fact, if you looked at HELIOS-B, 3% of patients were on SGLT2 inhibitors at the start of the trial. It's about a third by the end. And we cannot forget that palliative care really matters. You don't need to wait until your patient is ready for hospice to involve your palliative care colleagues. And from a symptom management standpoint, there can be a lot to be offered as well. This is just an interesting recent question. The standard practice has been to perform a transesophageal echo prior to every cardioversion in amyloidosis patients because of that high rate of left atrial appendage thrombus. This is a study that was recently published as a research letter in JACC that looked at whether we should really be doing this. And basically they said, look, we didn't do it in a bunch of patients and nothing bad happened as long as they were on anticoagulation. It's provocative. I don't know that it's ready to change practice yet for me. And I still, if I saw left atrial appendage thrombus, I don't think I would be brave enough to say, yeah, we're just going to move ahead and cardiovert anyway. But it's intriguing data. Dr. Rosenthal, do you still do a TE before every cardioversion in this population?
Yes, unless it's an emergency, I still do, because I've had a thromboembolic event happen in my career. And I think once you've had one, you really don't want another one. So I still advocate for a TE prior to cardioversion, regardless of them being on anticoagulation, given the atrial myopathy and risk of thrombus, despite being on anticoagulation.
Great. So now what? How do we choose between therapies? I think we're going to talk about a little bit with this with the next case, but I think the factors are to say are, is this a patient with polyneuropathy, with cardiomyopathy, or both? And then to think about them, at least in terms of grouping them, silencer or stabilizer. And as of now, the only therapies approved for polyneuropathy are silencers. And I would say that's really where the data is. So to me, if a patient has real polyneuropathy, they need to be on a silencer. If they have cardiomyopathy predominant, well, at this moment, it's tafamidis. That's the only thing approved. But it's going to become a lot more complicated, we think, soon if acoramidis and vutrisiran get approval, as I think we all expect to happen. So let's turn back to Malcolm to wrap up this section. So again, he was diagnosed with the hereditary form of ATTR amyloidosis with cardiomyopathy, polyneuropathy, and gastrointestinal involvement. Dr. Rosenthal, how would you treat him?
For me personally, with this patient, I would proceed with a silencer therapy because, as you highlighted, that data from NEURO-TTRansform, Apollo, and HELIOS-A is so striking. And this gentleman has a mixed phenotype. We don't have great neuropathy data from ATTR-ACT or the other former stabilizer trials. Even back in the day with diflunisal, we now know we have better stabilizers. So for me, it is no question I would proceed with a silencer. And then how to proceed, as you highlighted, we have 4 silencers available. I really have that a shared making decision between myself and the patient and what fits their lifestyle. While each of these silencers we did not highlight do require daily vitamin A supplementation, their frequency and ability to do either at home or in a healthcare environment are different. So providing them that information education, I think we have equipoise with all 4, and really only 3 are probably used more mainstream today. And soon I suspect it will be 2.
So with that, let's wrap up this section, and we'll move it to our final section with Dr. Rosenthal.
Welcome to Module 4, Multidisciplinary Models of Amyloid Care, Advancing Quality and Outcomes. You've heard this morning that amyloidosis can be a complex disease, but my hope is myself and Dr. Witteles have provided you with tools to initially recognize classic signs and symptoms of cardiac amyloidosis, as well as understand how to properly make the diagnosis. But I think you should each be aware that there is help around the corner. We don't expect you to feel confident and comfortable in making all the proper prescriptions and decisions when it comes to choosing which silencer for your patient, or hopefully in the near future, which stabilizer, and trying to think about potentially whether or not there's a role for multidisciplinary care. Some of these patients, particularly wild-type patients, might really just need a cardiologist, and you should still feel confident in being able to care for them. But my hope is you recognize there's a way to find an amyloidosis center of excellence if you need that, so that there can be a team to help validate that you have made the correct diagnosis, as well as help for your patients who are having a lot of extra cardiac symptoms, particularly those hereditary patients who might have a lot of GI or neuro involvement, like our gentleman Malcolm. So where can you find an amyloidosis physician? Once you've made the diagnosis, you might say, what do I do now? Aside from prescribing tafamidis, and how do I do that? Where can I get the help for my patient, or versus trying to find a silencer and going through that process? So the idea is you should reach out to your colleagues. Most academic centers in each of your states should have somebody who's helping to care for amyloidosis who can help you. And if you're not sure, please reach out to Dr. Google. I suspect you'll be able to find an amyloidosis center near you. But please know that people like myself and Dr. Witteles are here to help you. There are also a number of philanthropy programs around the country and support groups that can also be great resources, not only for you, but most importantly for our patients. I would strongly encourage each of you to consider offering genetic testing to your patient. As you saw today, there are a number of different genetic variants, and it's important to recognize that regardless of the genotype, not only phenotype can be different. For example, I have two Val30 Met patients. One is a cardiac phenotype and one is truly neuropathic. So not only can phenotypes be different, but penetrance and family members can also be different. And so I think offering genetic testing for your patient is important because it'll provide them opportunity at different medical therapies, as well as increase awareness for their patient, for their family members. As you learned this morning from Dr. Witteles, we have many different therapies, but regardless which therapy, each of these clinical trials showed that time to diagnosis and time to initiation of treatment matters. Each of these therapies will lead to progression of disease. None of them are yet to reverse the disease process. So we know if we start treatment early, we can hopefully improve not only the quality of life in our patients, but longevity. Dr. Witteles, anything else you would add here about finding an amyloidosis expert for our colleagues?
Yeah, I think you really nicely outlined it. And to me, the ideal world is a little bit of a hub and spokes model that I think that if we do the job we need to do as a community with increasing the diagnoses, it would be impossible for all the patients with ATTR amyloidosis to be cared for at an amyloid center. So I think it's really important that through educational efforts like this, that community physicians feel comfortable initiating the workup and maybe taking over some of the day-to-day management of patients. But I also do think it's important that patients have the opportunity to be linked in at least consultative capacity with an amyloidosis center, who, among other things, may also have clinical trial options for patients. So it's really the best possible world is when it's a partnership.
Excellent point. I forgot to mention the clinical trials. And obviously, none of these changes in the last 5 to 10 years could not have been possible without the participation of each of our patients. And so ensuring that referral so that patients can go to some of these facilities that offer clinical trials are imperative to continue to advance this field and move it forward in providing options for our patients as well as their families. I highlighted a little bit about genetic testing. This is a classic schema for genetic testing. One thing I didn't highlight is not only is it important for our patients to have genetic testing, but as well as to consider genetic testing for their family members. But I say this with two important things. I would not recommend testing asymptomatic family members without proper genetic counseling. I see that for two potential reasons. One, the emotional impact on their family members, whether or not they're going to be able to handle the fact that if they are gene positive, they may or may not ever manifest the disease. That can be quite a burden on an individual. So having some proper counseling and coaching of what that may or may not look like in their life, I think is important. The second thing is back in 2007, the GINA Act went into place, and that is to protect our patients living in this country from discrimination with regard to employment as well as healthcare insurance, but does not protect against discrimination from disability or life insurance. So having some proper counseling about potential ramifications, if that individual were to receive a positive test result, I think is most important. And so what do we do for these patients that are gene positive and phenotype negative? I'm curious what Dr. Witteles does in his practice. Currently, this is a data-free zone as well, but thanks to our colleagues who are championing this study, ACT Early, which is coming soon, this will actually look at what we should do for these patients. So this trial will randomize patients who are gene positive and phenotype negative to actually receive a TTR stabilizer, acoramidis, or receive placebo. So we can follow them long-term over about 5 years to see what will happen. Currently, in my practice, I personally just see them once every 3 to 5 years as a check-in, but provide them education regarding signs and symptoms to look out for. But I'm not de novo initiating them on off-label use of diflunisal or other agents. Dr. Witteles, I'm curious what you do in your practice.
I will often offer them diflunisal, but as you note, it's a completely data-free zone, and I make that point clear, and we just don't have an answer. You know, I think the ACT Early trial is an exciting one, and maybe in a number of years, we will have some evidence to guide us.
So with that, to wrap things up, we get back to our young gentleman, Malcolm, here. So he has been involved in a multidisciplinary team, given not only his heart failure symptomatology, as well as his neuropathic symptoms. If you recall, he had that numbness and tingling and this GI management. I will say for my patients, just like Malcolm, the agents like silencers have truly been a game changer for these patients in terms of helping to maintain their weight, prevent the diarrhea. But it's not that they're using a silencer alone. They do benefit from additional supportive agents in terms of antidiarrheals. Obviously, from a cardiac management standpoint, new tools such as SGLT2s have really been quite a benefit for our patients. In terms of how I monitor them, this is very individual specific and sort of what their needs are, but I really would encourage a shared care model. I don't think these patients need to be managed only at the Amyloidosis Center of Excellence. I think it's a team sport, and I think through educational seminars such as this, we're here to help you support and care for your patients. Dr. Witteles, anything you would add in terms of how you would manage someone like Malcolm?
I agree. For somebody with really multi-system involvement, they need care specialists from the various disciplines. And, I see a question of, will I manage or coordinate his care, or will the PCP? I don't think it's an either or. I think it's important that the patients still have a involved PCP, not expecting them to be amyloidosis experts, but among other things, Malcolm is age 60 and can have many things happen to him that have nothing to do with his amyloidosis. And so I'll sometimes have patients tell me when I ask them who their PCP is, they say, well, you are. And I said, no, I am not. I am your cardiologist, and maybe, as you said earlier, your amyloidologist, but I'm not your PCP. So, it's important to emphasize to patients this is one very important part of their health and health care, but it's not the only part. So it still remains very important for them to have a primary care provider as well.
Well, with that, I hope Dr. Witteles and I leave you with a few key takeaways this afternoon. First and foremost, remember, amyloidosis is truly not a rare disease. I challenge each of you to ask the question, could this be amyloid? The next time you see one of your heart failure patients with preserved ejection fraction and thickened intraventricular septal thickness greater than 12 millimeters, or perhaps one of your atrial fibrillation patients who are failing each ablation and having recurrence, or perhaps one of the patients you're evaluating for TAVR, recognizing those red flag symptoms to avoid missing a diagnosis of amyloid, such as bilateral carpal tunnel syndrome, neuropathy in the absence of diabetes mellitus. Please ask the question, could this be amyloid? Some of your patients might benefit from a multidisciplinary management team, such as our patient Malcolm today, but not all patients. My hope is myself and Dr. Witteles and I are providing you tools today to really know that this could be a shared or a team sport when it comes to caring for our patients with cardiac amyloidosis. It is so important that we not only recognize that this is not a rare disease, but work to make the diagnosis quickly and then initiate disease-targeted therapy, because we finally, for the first time in less than a decade now, have treatment to not only delay progression of disease, but more importantly, improve quality of life, as well as long-term survival. I think each of us in this seminar today are well positioned to take care of patients living with transthyretin amyloidosis. But the key is recognizing who we should be asking the question in. So please ask the question, could this be amyloid? Dr. Witteles, any final thoughts this afternoon?
Yes, absolutely. Thank you. Those key takeaways are each so important. I just want to hone in on that first one. It is not a rare disease. It's amazing once you start looking for it, how often you'll find it. If you think about it, particularly in older patients with thick hearts, and you start looking for it, you will find it. If you are a cardiologist and you have not made at least a couple of these diagnoses in the last year, I promise you it's not because you haven't seen the patients. You've just missed the diagnosis, which is understandable because this is something that has not been well taught until now and people really haven't thought about. But now that we can easily make the diagnosis, and just as importantly, we can do something about it and, in fact, have massive treatment effects, it really is incumbent on all of us to know about it, to look for it, and to make the diagnosis. I want to thank you, Dr. Rosenthal, for joining me today in the discussion, and let me turn it over to you to take us home.
Thank you again, Dr. Witteles. That ends our discussion for today. I hope each of you have found this activity informative and useful to your practice. Please don't forget to download the practice aids and slides for this activity by clicking on the appropriate icon in the menu. Thank you again.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an independent educational grant from AstraZeneca LP. To access all materials for this activity, visit peerview.com/TDS860.